Good evening. I'm here to make a test run for my speech. So let me go ahead and begin. I appreciate you watching. Um, Mario Mancelli, in 2010, a world-renowned filmmaker, actually ended up committing suicide simply because he was diagnosed with a mental disorder and was perpetually bedridden. So he ended up actually jumping from the window of his hospital room to end his life. And then 1 year later, a fellow Italian, actually, Lucio Magri, ended up he was an intellectual within the government and such. He made it quite the good name for himself, but he ran a very terrible life of his own in his personal life. And long story short, he decided that because of the same kind of mental diagnosis that he had received, same as Mario Monticelli, uh, that he was living in a torturous way of life. So he ended up actually wanting to end his own life as well. But he changed things by going to Switzerland and going with a physician's assisted suicide. So both of the gentlemen were actually living a similar kind of life, same kind of mental illness, although one decided to end it in a crude manner, the other one took it in a more humane manner. For the mentally ill or unresponsive to treatments, mental distortion is kind of the only basis they know. So it just kind of ruins the quality of their life, making their observation of their own situation and want of ending it quite realistic and a formula for their own personal normality. Um, in that sense, I myself have actually witnessed a great deal of things and experiences with cancer that have convinced me in the same sense that the quality of our lives is much more important than the quantity. So I, in that sense, have researched that the mandatory psychiatric assessment behind the physician's assisted suicide, written by Dr. Brendan Kelly in 2002, 1 year following the legalization of physician assisted suicide and the also known as Dutch Euthanasia Act. Um, I've also researched the medical journals written by Dr. Rosanna Secchi concerning the two voluntary deaths I opened with. And in addition to this, I've also researched Nancy Melville's article, Assisted Suicide for the Mental Illness Gaining Ground. Um, it exemplifies to many that who request the physician assisted suicide, though are actually denied, usually follow through in the crude manner that we're all very much aware of with suicidal tendencies. However, many who are actually considered seriously in their decision making process here and are offered the physician assisted suicide as an option for them eventually turn it down and continue with a desire to live. So, as I mentioned, the quality of life is actually a little bit more important than the quantity of it. So, in that sense, uh, number one of my topics here is following psychiatric analysis, physician assisted suicide should be considered as a humane option for the mentally ill. However, those rights are actually typically only given to the people that we consider as mentally sound because suicide in itself is actually considered a mental deficiency. And my third is the option of suicide often actually gives the mentally ill a reason to live, which is an interesting concept. So, in that sense, I'd like to transition into the psychiatric analysis conducted for all physician assisted suicide cases to determine the cognitive and decision making abilities for patients. I'll open this one with a Dr. Rosanna Secchi. She wrote an interesting assessment of how this is looked at, which she says assessing the suicide itself as an expression of mental illness classifies it as pathological, in turn means that a desire to commit suicide is invariably an expression of an inability to make decisions. This is important because it excludes the possibility of rational suicide in cultures around the world where it is actually considered ethically appropriate in certain circumstances. So, in 2011, Dr. Eva Belt at the Amsterdam Public Health Research Institute performed a survey in the sense that She asked about 1,500 general practitioners uh, the question as to whether they would assist a patient in dying. And 80% resulted in this saying that there was a high likelihood that they would for cancer patients or any other kind of physical disease. Only about 30% actually would consider it with the patients that had a mental illness. Um, Researchers at the Radboud University Nijmegen Medical Center actually determined in these current day and age that there's very little evidence that we can find to determine what unbearable suffering truly is. So this makes the doctoral analysis of such a status quite difficult. Um, it is quite subjective, of course, our own personal suffering. However, that in itself makes it kind of a road stop as far as a progress in helping patients in this ideology. New York Times has actually responded with this a report that suicides in the United States in itself has actually risen to the highest levels possible in the last 30 years, revealing that we are actually approaching the problem of suicide with both the mentally sound and mentally ill inefficiently and inappropriately. We're not quite doing it right. Um, I would like to, in that sense, then move along into the idea that rights are actually mainly only given to the mentally sound because suicide in itself is actually just considered a mental deficiency. It's a rather interesting topic because Jane Collingwood reveals in her article that for mental illness, only about 30% would consider helping the patient die. It means somewhat practical at that sense. However, there's only on that level 40% that would actually consider somebody with an early stage dementia that would actually help them die, even though that is still only considered a mental illness. However, that is a phenomenally torturous way of living, and we truly don't have any sort of realistic treatment for a mental illness like dementia these days. Um, in America, we actually only have about 6 states to this current day that would be okay with a legalized physician-assisted suicide. But even then, it is only considered for the patients that have a terminally ill physical illness. So we have California, Colorado, Oregon, Vermont, and Washington, and those are actually the states where a physician can make that decision. Even if it's arguable in that sense, they can actually make that decision if it's between them and their patient. Montana is our sixth state, but that is the interesting state because it is only offered, it has to go through a court ruling, has to be shot out by the court as something that can actually possibly happen. Um, I'd like to now discuss the option on the third right here that suicide often gives mentally ill a reason to live. It's an interesting concept. It truly is because Dr. Eva Bolt's survey that she conducted revealed that 80% of doctors asked would consider physician-assisted suicide for those with an untreatable physical disease. However, on top of that, Dr. Brendan Kelly committed a review as well of the mandatory psychiatric assessment behind each physician-assisted suicide, and she found that there is a growing um, discovery that there is actually a biological connection with a great deal of mental illnesses that is growing. It is somewhat new, but it is still continuing to grow with the mind and body connection of things. Um, it kind of commits to the argument that with the biological basis of mental illness, that by denying a patient on the option of physician's assisted suicide on the grounds it is only a psychiatric illness is actually quite discriminatory because it is becoming something that is actually now biological and psychiatric. Nancy Melville actually discusses within her article, Assisted Suicide for Mental Illness Gaining Ground, that most mentally ill patients just simply want to know that they actually have one choice in this world. She found that out of a larger number of patients that were coming to them, there were actually about 75 we were looked into, and it came to be about 60 or so that ended up going through with it, and it was mainly because it was a connection between mental and physical illnesses. However, the remaining 13 that were still there, that were offered, the idea that a physician's assisted suicide was actually possible and they only had a mental illness, they were still offered that as an option. And 8 of the 13 ended up actually turning it around. They had the mental disorder and they had the desire to end their lives. However, when they were given that as an option, as a possible way of ending things, they ended up actually turning it around. They just wanted to know that they were not denied the right to make that kind of decision. John Cutcliffe actually describes this a little bit further in his article, that by giving a mentally ill patient the option or right to end their own life may in fact turn the decision around as being the only solution and adaptation. So it makes it kind of interesting that by simply offering these kind of things to these patients, that it does in fact actually help them. They just don't want to be ignored. Um, I've now spoken to you about the fact that physician-assisted suicide is a rational option for some suffering with mental illness, even offering an opportunity to the mentally ill to continue living when the subject of suicide is no longer ignored for them. So I'd love to review the topics with you once again. I have number one, following psychiatric analysis, physician-assisted suicide should be considered a humane option for the mentally ill. My second topic being the rights these days are mainly only given to the mentally sound because suicide considered is mentally deficiency. The option of suicide actually has the weird option of when you offer it to a mentally ill patient, it often gives them a reason to live. So it's quite interesting how that actually does turn it around for them by just simply having that as an option, because a mental illness is quite subjective in its own subjectivity, but it does present phenomenal problems that only that patient knows. And when they have that as an option, it does help. Um, Putting them through like a swamp of pharmacotherapy is really no way of actually living for that patient. Um, it doesn't end their torture. It is, if they are cognitively available and are willing to try most every available treatment that we have these days, and there is just no way out of this torture, they should ultimately be allowed to make that one remaining decision in their life to decide whether they continue living or not. Studies completed by Brennan Kelly, Nancy Melville, and Dr. Rosanna Secchi have shown by denying a patient these options actually results in a higher ratio of crude suicides, whereas actually granting them the approval and giving them that option makes them feel recognized with a choice finally, thus actually resulting in a very new perspective on living and a desire to continue doing exactly that. Thank you so much for letting me practice, and I hope you enjoyed my speech. Thank you.